Hi, I'm Dr. Rich. I'm teaching you about dentistry and teeth so you can have a very nice smile.
Thanks for joining me today. Today we're going to be extracting this tooth number 14. This is an upper left molar. There you can see it's been root canaled and the crown snapped off. And so person came in for a cleaning. He said, "Hey doc, my crown feels a little loose." And I looked and sure enough, it wasn't a little loose, it was a lot loose. It's completely broken off. So doc talked about different options as to what to do, and he decided to get the tooth removed and an implant placed. This tooth could have been fixed up with probably a post and core and a new crown, but the person just wasn't interested in doing that. And also I find sometimes with root canal teeth, after they break the first time, there's chances are there could be other cracks in it. So we got them nice and numb, and then based on the x-ray too, I explained to the patient that there's a really good chance I'm going to need to section this tooth into the 3 individual roots to be able to remove it. But first, what I like to do even before, I don't go right into sectioning. I like to take my instruments. I'm using my spade proximator first, and I'm just working around the tooth, just to try to get some motion, just to try to get some movement into the tooth and the roots to get it loose. Sometimes I get lucky and I can get the tooth out without having to go surgical. If it doesn't come out, I still find it's time well spent, because now that I'm getting some movement in the tooth and it's getting loose, when I do go to section it, it's just going to make it that much easier to remove. And so first came the spade proximator. Now I'm going to use a little bit thicker instrument. This is my luxator with the gray handled luxator. It's got a little bit thicker tip, a little bit different shape, and I'm just working it in the same spots that I worked the spade proximator just to get the tooth moving. These tools do 2 things. The person was feeling it a little bit, so let me give him some more anesthetic. But basically, by forcing these instruments into the PDL space, the periodontal ligament space, it helps sever the ligament, and it also expands the socket. It makes the socket a little bit bigger. And then just by moving the tooth a little bit, the motion of the tooth, now I switched over to a 301. This is a thicker instrument. Again, I can get a lot more movement out of it. But there you can see it wiggling there. But it's moving the tooth. By getting the tooth moving, it's expanding the socket as well. But no matter what I do, I can't get it to come out, and there's not much left to grab with a forceps. So next step, we're going to suction it. So I get my surgical handpiece. Surgical handpiece is different than a regular dental handpiece. For one, the burr is a lot longer. We use a surgical length burr. Number 2, the handpiece doesn't blow any air into the surgical site. It will squirt some water. It's really hard to see. I think I had it turned down a little bit too low. But the air gets exhausted out the back of the handpiece, so it doesn't get blown into it. So now that I cut the tooth in half mesial distally, I'm going to go back to the 301 and just separate the 2 sides. So again, tooth's got 3 teeth, 3 roots, 1 on the palatal and 2 on the cheek side. And there we got, as I'm torquing it, I noticed that the palatal root's starting to want to come out. So we'll try to get it out just by elevating it up, and whoa, it popped out. I was not expecting it to pop out like that, but we got it. And now let's go on to the 2 buccal roots. These 2 are still connected. I haven't sectioned them, and I figured let's just try it with a pair of forceps, see if I can do it. But nope, the angles aren't conducive to them coming out. So again, I'm going to take my surgical handpiece, and now that the one root's missing already, this is where you don't want the air blowing up into the socket. And I just cut those 2 in half, clean it off so I can see a little bit better. There's a close-up of the palatal root. You can see it had a little bit of a hook on it, but it came out. It flew out there, and that's where it broke. So now there's the 2 buccal roots, so let's separate them with the 301. And again, I got them moving, and now we just got to remove it. So next I'm going to take my spade proximator again, try to get some more motion there. And now I'm working on the mesial root. That's the one closer towards the front. You can see it's moving pretty well there. And just got to work it all around, and I'm going to work it on the distal root too. A lot of times too, once you get one of them out, the other one comes out more easily. So now I got some more motion on them. I'm going to try to grab them with the forceps, but I'm having some trouble getting a good grip. So even though this is a pair of apical retention forceps, just the shape of what's left there, I can't get a good grip on it to pull them out and deliver it. So we're going to have to go back to the elevators, to the spade proximator, and the 301. So now I'm going to use the 301 on that mesial buccal root, and there you can see it moving up and out. And now it's loose enough that I can just reach in there, grab it with my fingers. the old finger forceps. And then the same thing with the distal root. There I just used the spade proximator. And there's the whole gang is right there. One big happy family, all 3 roots. Now we're looking, and let me pause this. So at this point in time, so the patient had decided to go to get an implant to replace this tooth. So typically what we do is extract the tooth, let the ridge heal for about 4 months, and then go back and place the implant. As I was reviewing this video footage at home a couple days later after I did this, I'm looking at the amount of interradicular bone. That's that area right there in the center. Let me circle that for you so you can see what I'm talking about. That's a decent amount of bone right there. I mean, I typically don't do immediate implants for molars, but looking back in hindsight being 2020, I think this would have been a really good case to do an immediate molar. All right, let's move on. Just checking to make sure there's no exposures into the sinus, and that's it. So thank you all so much for watching. Hope you enjoyed this video. If you liked it, please hit the thumbs up and consider subscribing to the channel so you don't miss any more of this content, and we'll see you next time. Thanks so much.